Hello, everybody. My name is Ranta. I'm a neurologist from Wellington, New Zealand, and it's my great honor to welcome you to our WSA webinar tonight. As you will all be aware, the topic is how does climate change affect stroke? And I will be chairing the session this evening. It's evening here, it's 11 o'clock in the evening in New Zealand. It's many different times around the globe, including for all of our speakers who are from all around the world. Conrado Estol will be moderating the Q&A session, and there should be time for questions towards the end. We'll keep all the questions to the end, but you can put them in the chat as the webinar goes along, and we will try to ask several questions aloud, and if we run out of time, we will try to get the speakers to answer them in the chat. And I just wanted to, before we get started, make you aware that we have recently approved a climate change policy for the World Stroke Organization. I'm going to put a link to this policy into the chat, which I encourage you to have a look at. This is from the WSO Policy Committee and was unanimously endorsed by the executive, which is very exciting and not something that all neurological and stroke organizations have done in other parts around the world. So we're setting a great example. So without further ado, we'll go ahead and get started. And I'd like to introduce our first speaker, which is Professor Yannick Béjot. He's a professor of neurology at the University of Burgundy, France. He heads the Department of Neurology, the Stroke Unit, and the Memory Clinic of the University Hospital of Dijon, France, and directs the research team Dijon Stroke Registry, whose aim is to study the epidemiology of stroke and TIA in a population-based setting. He's currently General Secretary of the French Neurovascular Society, and he will be talking to us how to identify climate change's impact on stroke and brain health. Over to you, Yannick.
Thank you very much. I'm going to share my screen. I think it's okay for you. Okay. So first, thank you very much for the organization committee for their invitation to this webinar. Here are my disclosure, not related with this presentation. So today we will talk about the epidemiological context of stroke. We'll try to identify mechanisms contributing to climate change and to provide an overview on the current evidence on the association between air pollution, temperature changes, and stroke, and we'll try to understand some underlying pathophysiological mechanisms of such an association. You know that stroke is currently the third leading cause of dailies worldwide, the fourth if you consider the specific period of 2021 because of the COVID-19 pandemics, and it is also the second cause of death. And despite we know that currently we are observing an ongoing demographic transition that is responsible for both a growth in the total population worldwide, but also an aging population. And this demographic transition is associated with some changes in the burden of stroke. Despite the fact that the incidence of ischemic stroke and the incidence of ICH is decreasing in high-income countries in the world and is stable in low-income countries, we observe increasing absolute numbers in both incident cases, prevalent cases, death, and dailies. So the projection for the next years is that by 2050, we will observe more than 200 million stroke survivors, 30 million new strokes each year, 12 million deaths from stroke each year, and also a significant number of people with dementia and death resulted from dementia, some of them being a consequence of cerebrovascular disease. So there is a need, of course, to improve primary prevention, but also to identify new targets that could contribute to this excess and this increasing number of stroke worldwide. And one of these challenge is the climate change. We know that increase in greenhouse gas emissions is the main driver of climate change. We know that anthropogenic air pollution, that's to say pollution that is induced by human activities, is responsible for the production of the majority of several pollutants. We will discuss more specifically ozone and particulate matter 2.5. These pollutants have direct effect on the risk of stroke, but also are responsible for increasing temperature at the surface of Earth, that in turn also increase natural pollution and so increases the production of pollutants. So if we discuss climate change, we have to discuss the consideration of pollution. What about the data concerning the association between air pollution and stroke? We have a lot of studies that evaluated the consequences of short-term exposure to pollutants and the risk of stroke. Here is a recent meta-analysis published less than 10 years ago that show you that all pollutants were associated with increased risk of stroke, and I will insist on PM 2.5 and ozone. If we look at this study, it is interesting to note that short-term exposure to PM 2.5 was associated with admission for ischemic stroke and transient ischemic attack. And as you can see, the association was observed with a short lag the same day of this increase in the levels of the pollutant. There was no association with hemorrhagic stroke. Another interesting result of this study is that we observe a dose-response effect. That's to say, with increasing levels of PM 2.5, there was an increasing admission for ischemic stroke or TIA. And this dose-response effect is highly subjective of a causal association. You know, in epidemiology, when we can demonstrate a dose-response effect, there is a causative effect that can explain this effect. What about ozone? Ozone has also been associated with increasing risk of both cerebrovascular and cardiovascular diseases, and short-term exposure to ozone was associated with increasing rates of admission for stroke or ischemic stroke. This is a study from China in which they demonstrated that the attributable number of strokes due to ozone pollution was about 80,000, which accounted for approximately 3% of overall hospitalization for stroke. In Dijon Stroke Registry, a population-based stroke registry, we conducted this study a few years ago in which we also demonstrated a dose-response effect. But once again, with increasing levels of ozone, we observe increasing incidence of ischemic stroke from one-day lag. And we also demonstrated that this association was particularly pronounced in patients with vascular risk factors, hypercholesterolemia, diabetes, hypertension, and tobacco use. And we also demonstrated that in patients without any vascular risk factors, there was no association between ozone levels and their risk of ischemic events, including both ischemic stroke and myocardial infarction. We have less data from studies about the consequences of long-term exposure of pollutants with the incidence of stroke or cerebrovascular mortality. We have this meta-analysis that was based on a limited number of studies, and most of the time small study, that concluded to an association between long-term exposure to PM 2.5 and the risk of incident stroke and mortality from cerebrovascular diseases. So if we want to summarize first the direct effect on air pollution on stroke, and especially ischemic stroke, we can say that pollutants are associated when long-term exposed to stroke, because they can be regarded as a risk factor of stroke, whatever the background of the patient. That's to say, everybody is concerned by these risk factors. To the opposite, short-term exposure can act as a trigger of ischemic stroke, but more importantly in patients with prior traditional vascular risk factors, and the effect is probably less marked in patients without any vascular risk factors. So what about the temperature changes and the risk of stroke? The study conducted in Madrid in Spain showed that increasing temperatures were associated with increasing rate of ischemic mortality, ischemic stroke mortality, and ischemic stroke hospital admission. And this association was observed with a short with a short lag of 0 to 1 or 2 days. And there was also an association between low temperatures and ischemic stroke mortality and admission, but with a longer lag of 3 to 8 days. The study conducted in China was very interesting because the measurement of temperature was done each hour. And as you can see, a transient exposure to high temperature was associated with ischemic stroke, and the association occurred at the concurrent hour and lasting for up to 10 days. That's to say, any increasing in temperature have an immediate effect on the increasing risk of ischemic stroke. And they also demonstrated that the effect was particularly pronounced in patients living in northern areas more than in southern areas, thus suggesting that people living in southern areas are exposed to higher temperature than exposed to northern areas, and probably they have a kind of preconditioning, and the consequences of increasing temperature are less observed in southern than in northern areas. They also demonstrated that the effect was particularly pronounced in patients, once again, with vascular risk factors, especially with dyslipidemia, and you can see that the odds ratio was very high in these patients. In this study conducted in New York, they also demonstrated the same result, that's to say, a rapid effect of increasing temperature on increasing the risk of ischemic stroke, but they also demonstrated a negative effect concerning hemorrhagic stroke. So to summarize the current evidence from the article from Anna published this year in stroke, we can say that the current evidence supports an acute effect of ambient temperature on all types of stroke, and we have more consistent results from stroke mortality than for stroke admission in the literature. The increased risk is observed for both high and low temperatures, and hot temperatures have a more immediate effect with a lag of few hours or few days, whereas cold temperatures have a longer lag effect, several days or weeks, and closely associated with hemorrhagic stroke. This paper was recently published in Neurology and tried to identify the global burden of stroke attributable to non-optimal temperatures, and the conclusion was that more than 500,000 deaths and more than 9 million deaths could be attributable to stroke due to non-optimal temperature. There are increasing absolute numbers despite decreasing age standardized rates. The trend is particularly marked in low SDI countries. Low temperature currently contributes to the main burden, but the burden attributable to high temperature has been rising rapidly, especially in low SDI countries. Beyond the effect of temperature, climate change is associated with other phenomena. For example, this study conducted during bushfire in Australia clearly demonstrated that high bushfire smoke days were associated with increased total daily number of hospital admission for acute stroke or ischemic stroke. And this association was probably explained by increasing levels of some pollutants, including PM10 or PM2.5. In the US, in California, the wildfires in 2015 were also associated with increasing risk of all-cause cerebrovascular diseases, especially in people age older 65 years old. And we have some projection that has been published, depending on the scenario considered, up to a 100% increase in ischemic stroke related to high temperature will be observed by 2080. To conclude, some pathophysiological mechanisms that have been reviewed in this paper recently. We know that concerning air pollution exposure, it is associated with an initial response that can lead to platelet aggregation or activation, neuroinflammation, systemic oxidative stress, and autonomic nervous system imbalance that are both responsible for thrombosis, atherosclerosis, plaque vulnerability, metabolic syndrome or insulin resistance, hypertension, and arrhythmogenesis that all contribute to the risk of ischemic stroke, but also in a lesser degree hemorrhagic stroke and other ischemic disease such as myocardial infarction. And regarding high temperature, we have some data suggesting that high temperature are associated with peripheral vasodilatation, sweating and evaporation, volume depletion and electrolyte imbalance, hemoconcentration and hypercoagulable states, sympathetic activation, tachycardia and arrhythmias, and also endothelial inflammation, atherosclerosis or plaque rupture that together can contribute to increasing the risk of ischemic stroke. So to conclude, this is a very nice overview by Anna Ranta in her paper this year in stroke. I just discussed the direct effect on air pollution on increasing burden of stroke and the effect of climate change, just considering the direct impact, but there are also indirect impact due to healthcare infrastructure damage or to poverty or population displacement I have not discussed today. So thank you very much for your attention.
Thank you very much, Yannick. That was a great overview to get us started. And now I would like to hand over to Ali Saad, who will be talking to us he will be exploring a case study of a patient with climate-related social determinants of health affecting their stroke risk. And Ali is a US-based neurologist. He's board certified in neurology, stroke, and lifestyle medicine. He's completed a fellowship in climate change and health policy at the University of Colorado's Climate and Health Program, where he's currently affiliate faculty. And Ali is also very much involved in the Niche Group, which is a US-based group of neurologists interested in or concerned about climate change. And he's been very actively reaching out to other groups around the globe, which is how I met Ali, and all of us have met Ali. So thank you very much, Ali. Also, he's instigated this webinar, and over to you.
All right, thank you so much, Dr. Ranta. My slides showing okay? Hello?
Yes, it sounds
yes,
perfect.
Okay, all right,
perfect.
Thank you. All right, go back here. All right, so yes, I apologize in advance if I'm not very eloquent. I was on call last night, but I will do my best, so please forgive me. So we're now going to take a look at how some of these risk factors that Dr. Béjot discussed come into play during everyday life, using a clinical case as an example. And then we're going to end with some mitigation strategies to address these risks. So a patient comes to the emergency room and neurology is consulted for altered mental status. Here's the information provided by the EMTs and the patient's list of medications. Whoops, sorry. She was found down by her neighbor who called EMS. She was last seen normal the day prior, and she has a history of hypertension, diabetes, chronic kidney disease, and mild cognitive impairment. She's on the usual medications for metabolic syndrome, as well as lorazepam as needed. On exam, she is laying in bed non-specifically encephalopathic, not speaking or following instructions, but also non-focal. Her general exam also suggests dehydration. Her labs show a mildly elevated white count, acute kidney injury, and some rhabdomyolysis. The patient's too encephalopathic to provide a history, so the neurologist orders a CT and CTA of the head and neck. While waiting for the imaging, they also decide to call the patient's neighbor to get some collateral information. So per the neighbor, she lives alone in an apartment building downtown in a metro area. She manages her own medicines. She is widowed with no children. Her neighbor visits her a few times a week. The building is older and doesn't have air conditioning. And there's usually heavy traffic in their area, so she usually keeps her windows closed. And because her neighbor usually joins her for a walk every afternoon, that's how she discovered her. Her imaging, as you can see here on the left side of the screen, shows a partial right middle cerebral artery stroke. And the CTA to the right of the screen shows a right cervical internal carotid occlusion of unknown chronicity. So although this patient has traditional vascular risk factors, as neurologists, we know that there is often a trigger for someone to come in with a stroke on that particular day that they present. And that could be the cigarette that they smoked earlier that day. That could be the urinary tract infection they're developing. And just like traditional health risk factors, the health hazards associated with climate change also have acute and chronic components, as Dr. Béjot alluded to. And the key mechanisms for these are, of course, air pollution and extreme heat. And we've seen extreme weather events, including extreme heat, become not only more severe, but more frequent due to climate change since the 1980s. And these hurricanes, droughts, and wildfires do things like destroy homes, impact food and water supply and infrastructure, which all threaten people's access to food, water, education, safety, and medical treatment, which are the basic social determinants of health. In addition to causing direct health harm, air pollution from a higher atmospheric concentration of CO2 also decreases the nutritional yield of key micronutrients in crops like iron, zinc, and B vitamins. And these are the chronic ways that climate change affects health. Acutely, days with higher than average ambient temperatures or poor air quality are associated with higher visits or higher rates of ER visits for several conditions, including strokes. And then this happens by the mechanisms of systemic inflammation and physiological stress that Dr. Béjot alluded to. So that could be an explanation as to why that particular day, the patient might have had an embolization from her right carotid or plaque rupture in that right carotid. And here's a graphic summarizing some of those mechanisms behind high air pollution and high temperatures affecting stroke risk, which I'm not going to go into again. So you can imagine that the people who are most at risk for health harms from climate change are those who are already burdened with chronic conditions or are under-resourced. And this is what the data reflects. Elders and those with mobility issues may have trouble seeking shelter or evacuating during an extreme weather emergency. Those who are socially isolated due to age or being part of a marginalized population may not have people to check on them during extreme weather events, including heat waves. And those of low socioeconomic status may not have access to air conditioning or even be able to access public spaces like shopping malls or cinemas during heat waves that might serve as a refuge from the heat. And when infrastructure gets destroyed by extreme weather events, such communities may not be able to build back those resources and that infrastructure quickly or at all. And such scenarios are not uncommon, and they're also not limited to low to middle income countries. In 2022, more than 61,000 people died in Europe from the record-breaking heat waves, with the highest loss of lives recorded among those over age 80. Elders and those living with chronic conditions are also at increased risk of side effects from medications that are exacerbated by heat stress. Things like sedatives and antipsychotics are more likely to cause sleepiness and impaired mobility in older adults, which can impair their ability to seek safety. Diuretics can contribute to dehydration. Anticholinergics can exacerbate parasympathetic inhibition, interfering with sweating and reducing blood flow to skin. SSRIs can increase sweating and increase the risk of dehydration. Tricyclics can decrease sweating and also the ability to regulate core body temperature. And lastly, insulin may not be able to be usable if it's not kept at an optimally cool temperature. It's also worth noting that people are more likely to abuse substances like alcohol and illicit drugs, not only during climate stressors, but also just during high ambient temperatures. And this is associated with an increased incidence of domestic violence. So you can see how both the acute and chronic contributions of climate stressors play into many of the same traditional stroke risk factors that we're all familiar with. This graphic is from the World Stroke Organization showing the 10 risk factors that account for about 90% of global stroke risk. The availability of healthy food, a safe environment to remain physically active, staying hydrated to avoid kidney injury, which, as a side note, has become a huge population in migrant agricultural workers. And now even air pollution has become an independent stroke risk factor within mainstream recommendations like this one, accounting for 20% of global attributable stroke risk. This surprisingly large number is driven primarily by the disproportionate number of strokes in low to middle income countries, as well as the relatively high levels of air pollution these countries experience. We can see the uneven distribution of poor air quality across the world. This graph shows in the y-axis air quality index, AQI, which is a composite of multiple air pollutants that determines air's quality. The higher the number, the worse the air quality. And it's largely driven by a particular component of air quality called PM2.5, which is a pollutant that measures about 2.5 microns or less in diameter and primarily comes from the burning of fossil fuels. In the x-axis, we see the level of PM2.5, and you can see this direct relationship between local PM2.5 level as well as air quality index. Many countries in Asia and Africa bear the brunt of worst air quality, as you can see at the top of the graph. And climate and health research is important because it impacts health policy. A great example of this is how the Environmental Protection Agency, which regulates air quality in the US, lowered its acceptable limit of PM2.5 from 12 to 9 micrograms per meter cubed because of research showing worse health outcomes seen even seen even at 12 micrograms. Although I do want to note that what the US considers an acceptable level of air quality per the EPA is still higher than what the WHO deems as an acceptable level of air pollution. And even within the US, there is inequitable distribution of air quality. More than 1 in 3 Americans live in places with unhealthy levels of air pollution. And people of color are nearly 4 times as likely than their white counterparts to live in an area with at least 3 failing grades of air quality as determined by the American Lung Association. And so this gives context to the idea that one's zip code is on average a bigger determinant of one's health compared to one's genetic code. BIPOC communities are more likely to be fence line communities. Fence line communities are those that are living adjacent to industrial waste facilities, or ones that produce a lot of air pollutants or other pollutants like industrial factory farms. And these fence line communities often transform into something called sacrifice zones. This is land that's been determined to be of low economic value, inhabited by people of low socioeconomic status, and therefore used as a dumping ground for high levels of pollution and destruction of natural resources, such as forests and bodies of water, which we term green and blue spaces, respectively. Having green and blue spaces is important for physical and mental health, unrelated to heat and air pollution. They provide space for exercise, fresh air, and relaxation. However, this scoping review published earlier this year on green spaces shows the impact on stroke. It concluded, or it found, I should say, 27 papers around the world, and it found a statistically significant association between green spaces and death and disability related to stroke, but there was inconsistent evidence related to stroke incidence. So how do we incorporate this knowledge into clinical practice? Just like we counsel on diet, exercise, and substance abuse as modifiable stroke risk factors, we should be doing the same for extreme heat and air pollution for our patients. The patients neurologists see are often those at extremes of age or those living with disability related to other neurological conditions, such as multiple sclerosis, neurodegenerative disease. These are populations that are particularly high risk, as we've seen. And the way I like to explain air pollution to patients is it's kind of like secondhand smoke. If you're around it a lot for the course of many years, it increases one's risk of having a stroke, as well as other medical problems that predispose to stroke. So I've compiled a list of potential solutions from most to least accessible. Starting at the top, at the very least, we can be screening our patients for social isolation. People who are connected to their community are more likely to be checked on and provided assistance during emergencies. Those with family members can be educated to check on their elders and those living with disability during heat waves or days with high air quality index, and remind them to stay hydrated, avoid the outdoors during midday, and to access cooler environments if that's possible. And for people that already have technologies like smartphones and programmable thermostats, they can be automated to trigger alerts about extreme weather events, high air pollution and high heat, as well as automatically turning on at extremes of temperatures. But more important than counseling our patients, we need major neurological societies to fund research to validate such measures, to issue best practice guideline recommendations that these measures be taken, and to tie health system certification and reimbursement to these measures. This would help address climate change's impact on social determinants of health, which we know are the largest drivers of death and disability. And I was so glad to see the recommendation from the World Stroke Organization that Dr. Ranta shared at the beginning of the webinar. So here are the 5 key take-home messages from my portion of this presentation. Climate change is a novel social determinant of health that interacts with traditional social determinants of health. The 2 key mechanisms of climate change related to stroke risk are heat and air pollution. Those at extremes of age and already marginalized populations are at greatest risk. These same risk factors also affect Alzheimer's, Parkinson's, migraines, and other major causes of neurological morbidity. This has been described in a scoping review from 2002. And actions can and should be taken by clinicians to mitigate this risk. Here's my contact information with my email and my LinkedIn with the QR codes. Thanks for your attention.
Thank you, Ali. That was really nice summary, and it's a great springboard to get us started on the next presentation, which is going to be provided by Dr. Sarafna Öztürk, and she will be talking to us more about more actions we can take as clinicians to mitigate climate change at various levels. Just carrying on right from what Dr. Saad finished off with. And Dr. Sarafna Öztürk is a professor of neurology and head of the neurology department and stroke center of the Selçuk University Faculty of Medicine in Konya, Turkey. She has over 150 publications, is the former president of the Turkish Neurological Society and a member of many national and international committees, including the chair of the World Federation of Neurology Migrant Neurology Specialty Group and vice president of the World Federation of Neurology Environmental Specialty Group. I will hand over to you now, Sarafna. Thank you.
Sorry.
We can see your slides very well.
Okay. Just okay. Yeah. Thanks a lot for this very important invitation on climate change and stroke. I thank you. I thank organization committee, and I'm grateful for their support and help during all this process. And thanks again, Professor Ranta and other colleagues who contributed to this important webinar. Now, my task is highlight our action. What can we do as neurologists, as doctors, as human being? Actually, because this is a total, this is a unique one health problem actually, and we must contribute. We must try to solve. We must share. We must increase each other's knowledge and information. So these are our learning objectives, actions, what we need. There are some individual and collective tasks that we can manage. You have seen the important amount of neurological disease burden, and we have to protect our especially target groups. These are elderly individuals, children, indigenous populations, ethnic minorities, and also today's problem, refugees and migrants. These are main contributor of environmental risk, air pollution, mainly talked, biological aggressors, urbanization, endocrine disruptors, water and soil pollution, and naturally climate change. But we have a huge options also. We have a very badly managed environment with climate change, with air pollution, but we have a potential also that environmental risk factors are non-genetic, external, and manageable. We can manage it, and we can change it. We can stop air pollution. We can stop climate change. So there are some tasks for us as professional, like observing climate and take action for environment, effort to decrease the health burden, education, advocacy, special prevention of strategies, special care, research. And as an individual, again, advocacy, research, travels, changing our lifestyles, and becoming role modeling. And there are also some collective tasks, collective responsibilities. Again, we must do advocacy for each other. Social and economic impacts are important. We must do networking. Political acts and research are also very important collective task. So we must have some priorities for research. And unfortunately, we have not many good quality research on climate change, on air pollution, and stroke or other neurological disorders, because this is a really very heterogeneous area, because we have different population, different pollutants, different and changing climates, and different neurological disorders. So we must take into account all these factors. And relations for climate change, air pollution, and neurological disorders. Sometimes these are, mostly these can be together, because climate change and air pollution are related to each other. A new concept, epigenetic change and hormones, must be a topic for research, because these are also changing with climate change. And green spaces must be another area. Short time and lifetime cumulative effects of pollutants, and maybe we must evaluate climate change also for long time. And research into green spaces, partnership also important. during research. We must research health inequalities because you have learned that we have learned that there are many important differences between low-income countries and high-income countries. And we must make some investigation to achieve behavioral change to adapt healthier planet and friendlier lifestyles, actually. And education is always very, very important. And climate issue is an important and new area for awareness and education. Public education must be done continuously to improve brain health and reduce the global burden of neurological disorders. And during this education, we must show close proven reports and studies to our shareholders to increase awareness for climate change and its effect on neurological disorders, especially on stroke. And promotions can be useful in social media like cinema, television, other printed media, all kind of brochures you can use in your department, in your hospital, in markets, even in markets must be used. These are another potential tools. And smartphones. Every individual has a smartphone, so we can use this very high potential tool to increase education and awareness. And another important area, medical school. During the medical school, we must include awareness and information in core curriculum, in learning objectives. There are some role modeling, some samples in some medical faculties. You can see preclinical years of training and learning objectives and clinical years of training and again learning information learning activity for climate change, environmental factor. So we must increase the conscious in medical school students for environmental factors. And advocacy, again, very important. As neurologists, we must increase our voice to prevent the environment and to force making some difference, some changes to prevent climate change. And there are many areas that advocacy can include. We must advocate at local, regional, national, and global policy as in the global policy level for environmental factors and relationship for neurological disorders. And again, as leader neurology in neurology area, we can again use our voice to reduce the social and economical inequities and access to green spaces. These are important for prevention. And there are some important collaboration that we must use, we must engage, like WHO. Another important population to protect refugees. And we know about migration effects. There are important effects of environmental factors on refugee migration period. This is a new concept, environmental refugees. We have now environmental refugees. And these are persons displaced in the context of disasters and climate change. So they are changing their countries, their home cities, home village, home, their own lifestyles. So climate, environmental degradation and natural disasters increasingly interact with the drivers of refugee movements. So we must be aware of this. And there are some different migration types, and every kind are under threat. The most frequent diseases in immigrants, cerebrovascular disorders, cerebrovascular diseases, and mortality rate was higher. So we must do something to change this. And as countries, as societies, we must make effort because the awareness to improve healthcare for the migrants must be initiated during the medical education. Also, we must increase these awareness, these sensitivity to this group during the medical education. And we have WHO report for 2030. This strategy aims to provide a vision and way forward on how the world and its health community needs to respond to environmental health risk and challenges until 2030. This is a very important message related to environmental changes and actions. Primary prevention, according to this report, primary prevention is important, and health and environmental dependent behaviors and risk are really very important, and we must change this. And we must help all countries in low income and high income. There are some key platforms, multilateral, regional, and global policy platforms, and even emergency platforms. And leadership and policy is important. We can influence political leaders as medical leaders. We must provide leadership on health, environment, and climate change. And as neurologists, we must educate our patients. We must ask for the air pollution situation in their home cities, home areas, and we must incorporate climate change and air pollution into training programs, as I said. And we can work within health system to reduce the large often unaddressed magnitude of greenhouse gas production. So we must influence to every area, and we can improve our individual efforts. We can decrease our own carbon footprints. For example, we can change travel style, and we can use more of environment-friendly tools. This is from epilepsy specialist, but we have the same. This is a contribution to air pollution with air travel because of Congress and meetings. And we must encourage our neurological societies to join environmental organizations, and we have some urgent solutions. We must recommend activities in nature. We must promote advocacy for more urban green spaces. We must promote more development of public transport and walking way, suitable environment, eating predominantly local, unprocessed, plant-based foods, drinking water, more individual, measuring individual exposure, and naturally to be role models. Again, you see all these relationship. And as a conclusion, environmental risk factors are non-genetic, external, and manageable. In contrast to individual risk factors, their management will be much more effective if targeted at the level of our community. So community efforts are really very, very important. Individuals can support also this effort through individual and collective actions, advocacy, service-level initiative, role modeling, and research. And effect of environment, air pollution, and climate change on health and prevention of neurological diseases, including stroke, has become exceedingly critical areas for research, for our research and advocacy around the globe for all neurologists who are working on this area. Thank you very much for your attention.
Thank you very much, Serafino, for a wonderful talk. That brings our presentations to an end, and we will open the Q&A session, and I will hand over to the moderation to Conrado Estol, who will also introduce himself. Thank you.
Thank you.
Thank you, Anna. I hope the microphone is working. And I'm Conrado Estol. I'm a US trained and board certified neurologist, and I'm director of a stroke unit in Buenos Aires. First, congratulations to the speakers for excellent presentations, and mainly for calling attention for something so important that most people in the world and many physicians don't even know about, on the effects of climate change and air pollution on health, and specifically on cardiovascular health, on cardiovascular disease. So I think first it's appropriate to call this climate crisis more than climate change. People should know, the audience should know, as was mentioned briefly during the presentations, that air pollution is a risk factor for stroke considered like that by the American Stroke Association, European associations, and the WHO. And just to put dramatically in numbers, 7 million deaths per year from air pollution, 60% are cardiovascular deaths, and that it has become the 5th cause of leading death in the world, air pollution alone. And of course, I live in Argentina, and air pollution and climate change affect 80% of the effect, and the disease affects emerging countries. So as it usually happens, most cases are in emerging countries. The questions I would like to discuss, or just to take for Ali, Yannick, Serafino, two issues to start with. One is cryptogenic stroke is so uncomfortable, so bothersome, like having 20 to 40% of strokes that you don't have a cause. Well, air pollution could be one. So when we talk about the acute effects of air pollution, and we know this happens, the mechanism has been briefly mentioned by Yannick and Ali when they said platelet activation, lipids, plaque vulnerability. I would like to know if they can elaborate a little more on what would they consider the acute mechanism for stroke. Ozone was mentioned by Yannick in the gaseous part, non-particulate matter, and the particulate matter 2.5. But chronically, we understand how it works. Acutely, what would they say is the main mechanism for stroke, and whether this could be a significant part of what we call cryptogenic strokes, those patients that come to the emergency room and don't have any risk factor, but they have had a stroke. And the second one, Ali went into that, masks and filters. Shouldn't be saying more strongly that buildings now and in the future should be built with air filters throughout the world, and especially in certain parts of the world, India, China, Asia, where the highest rate of air pollution is, filters for buildings and masks for our patients. I don't know a young, healthy patient, but if one of my patients with vascular disease goes to Delhi or goes to China or goes to high risk, high pollution areas, maybe an indication should be take your medications, eat a Mediterranean diet, but also wear an N95 mask because your risk of a stroke is significantly increased. So the two, acute mechanism for stroke And could this be part of the cryptogenic stroke group? And second, filters and masks for patients and buildings. Thank you.
Perhaps I can answer the first question about the cryptogenic stroke and the acute mechanisms. We agree that we know that chronic exposure to pollutants are associated with what we know as atheroma, atrial fibrillation. But I agree with you that in some patients with pure cryptogenic stroke, that's to say without any proof of atheroma, of arrhythmia, it is difficult to understand why at a moment they have increased thrombogenicity. And I think that one of the arguments, they have probably multiple explanations, but pollution, acute pollution can be a trigger, an acute trigger in this patient to increase the platelet aggregation, for example, and create a thrombus, or to increase inflammation that can be responsible for also increasing thrombogenicity. So I think that we cannot totally prove the association, but perhaps we have to more deeply concentrate on this cryptogenic stroke to evaluate the association between air pollution and stroke. The problem is that in epidemiological studies, most of the time there are no differentiation according to the cause of ischemic stroke. So it is difficult with current data to have a perfect conclusion, but we need more studies focusing on the etiology of ischemic stroke.
Thank you, Yannick. Regarding the comment about increasing air filters and maybe wearing masks, I think those are very reasonable things. As you suggested, that's something I do with my patients. If I have someone with a particularly high stroke risk, I tell them if there's a high AQI day or you're going somewhere where there's high air pollution, or if in the western part of the US, for example, we experience a lot of wildfires in the summer, I recommend that my patients wear an air mask, but I also qualify that with the fact that this is not a validated and tested measure. It's not something we have a recommendation from a mainstream medical society to do, but I think it's an easy and common sense thing to do that's low risk. So I do recommend that. But I think in order to have measures like changing policy to have buildings have more stringent air filtering, I think we do need research to justify the cost, only because I see it difficult for governments to pass these sort of things. I think they need to see research showing that it is necessary and that it's also cost effective to do so. But I would love to see that.
I think, I'm going to pop in, I think, is the claim. There are a couple audience questions, and I just want to, some people have their hands raised. We cannot take live questions. Please put your question in the chat, in the Q&A section. There's a question about whether the panelists could comment on the burden of climate change on neurodegenerative disorders. And just briefly, we only have a couple minutes left. I'd like to ask at least one more audience question, please. Anyone want to take that one, Srefno?
Yeah. Yes, actually, there are recent many studies done recently with the increasing of importance of this subject, especially for dementia and Parkinson's disease, epilepsy. Even for epilepsy, there are many studies, and there are some reports which are showing some relationship between neurodegenerative disorders and changing climate, but these are all very heterogeneous. So changing climate change is really very difficult to measure for every area, for every population, living population area. So we need more promptly structured studies, trials to say this, but it seems positive, actually, a strong relationship between neurodegenerative disorders and climate change. But more than risk, there are also some important advantages with climate change for neurodegenerative disease patients, because they have already very limited, isolated lifestyle in their home, without moving to outside, without promptly managing their home living conditions. So they are under a higher risk because of climate change.
I think we may have to finish, unless Conrado, did you want to put in one more audience question, or?
Audience question. Well, was not looking at them, but
There was a question about wearing warning watches. Masks has already been addressed, but sort of any kind of this also. I don't know if any of you talked about devices people can wear to assess air pollution and temperature warning devices. We did talk about it a little bit in our papers. Anyone? As far as I know, we don't have a lot of evidence on those devices yet. They kind of make sense. But I do think that's an area that could really do with a lot more research. So I think in addition to, we have quite a number of papers talking about the effects of climate change on stroke. We need more, but what we really need more is more effective treatments around mitigation strategies that work. And Ali also alluded to the lack of evidence around masks. So there's some very intuitive solutions, but we really need more evidence, just like we do for other interventions.
There are, Anna, there is a study on students on a building, half of them with filters, some with not, and they measure acutely many reactants in the blood, and there was a significant difference. But more, I would say, in the Masai Mara in Africa. They live in little huts. The women stayed inside with the children, and they cook inside, and they warm the huts with fire inside, and they have been developed machines to decrease the smoke they breathe, because they shorten their lives by years, decades, by smoking, inhaling that smoke inside the hut. So there is much that can be done with filters, mechanically, or devices. And there is some data.
I agree. There's some data for house filters. I was talking about like wearable devices for detecting temperatures, but thank you for pointing that out. And you can, anyone has any data, feel free to put it in the chat. I do think we need to close the webinar now. Thank you for all of the questions, and I see somebody else has a hand raised. Sorry, we cannot take live questions. You can pop it in the chat, and maybe one of us can still quickly answer the question for you. We thank you for the question about the slides. I think most of the speakers have agreed to share their slides. The webinar is recorded and I believe will be posted on the website. So look for that, and we'll put the slides there as well. So I will finish us off. Thank you very much to all the speakers. Excellent talks, a really interesting topic, very important topic. And I hope everyone has a lovely day and or a lovely night. Thank you, everybody.
Thank you.
Thank you very much.
Thank you very much. Bye-bye.
Thank you. Bye-bye. Thank you.